Welcome, my dear students, to charts in hematology. As I had mentioned earlier, it is not just a practical chart, but encompasses all format of questions that are possible. The class for today is megaloblastic anemia. There are various terms that could be used for it, and they include megaloblastic anemia, pernicious anemia, B12 deficiency, folic acid deficiency, so on and so forth. So I would like you people to kindly pay your kind attention. As I had mentioned in the previous class, the first parameter shall be the peripheral smear. There is a normal inset that is shown over here, the RBCs. Whether they are normal or not, I shall compare it with the lymphocyte. That being one thing. In the picture that is lower down, so these are normocytic, normochromic RBCs. In the picture that is lower down, I find that the RBCs are large. They are not only large, but then they are varying in size and shape. We call it as anisopoikilocytosis. One of the characteristic features of a megaloblastic anemia will be ovalocytes. We call them as macroovalocytes because the cells are enlarged and they are also oval in shape. Please do observe that there are some teardrop cells which are seen in this. Some cell, it has got a purplish tinge that is called a reticulocyte or a polychromatic cell which can appear due to treatment. So macrocytosis, anisopoikilocytosis, macroovalocytes, and teardrop cells. There can be some inclusions such as Hall-Jolly bodies and Cabot rings which are present. Also, in the WBCs, there is one peculiarity that could be seen. This is a normal neutrophil, and in this I find between the bead is a segment. So it has got multiple segments, more than 6 to 9. Normally it is 2 to 5 according to the R.A.T.S count. But here it can be 6 or even more. And when more than 5% of the cells have got that, we call it a hypersegmented neutrophil. So that will be the peripheral blood picture. There will be some amount of hemolysis. So there can be an increase in the serum bilirubin. Also, you find that there will be a decrease in the hemoglobin. MCV will be increased and MCH can be normal or slightly decreased. After the peripheral smear, I am going to the bone marrow. There are other things, but we shall follow this particular protocol. So this is an insert showing normal normoblast. So these are cells. This is an RBC, probably a hemorrhagic aspirate, and I'm finding some normoblast, and it is almost as mature as this, a late normoblast. But what you should observe will be, look at the condensation of the chromatin in the cell. It makes it look dark, and it is much smaller than the counterpart seen over here. Look at these cells. These are the megaloblasts that we are talking about. In a case of megaloblastic anemia, as will be described, there is always a lag of the nuclear maturation behind the cytoplasmic maturation. That is, there is a delay in the nuclear maturation. The nucleus is large. It does not get condensed. Normally, it should get condensed, become small, and it should disappear. But it persists, it is large. Also, you find that the chromatin is pale. We used to call it a opened out chromatin. And it will be in the form of a fine sieve. Sieve means it is something used for filtering the flour in the kitchen. So this is a sieve. A sieve like chromatin, large nucleus, and increased nuclear cytoplasmic ratio, lag of the nuclear maturation behind the cytoplasmic maturation. These are the features. There will be the other things, but all the series can be affected because It is a disease that affects the DNA. DNA will be found in all the nucleated cells. So what happens? This is a granulocytic series, and there are some cells, C-shaped cells, which are the stab forms. Stab forms, metamyelocyte, and then the stab form. These cells are large. We call them the giant stab forms. Similarly, the megakaryocytes also can be slightly immature when compared to the normal bone marrow smear. So this will be it. The bone marrow is usually normocellular, and you find that there is an increase in the erythropoiesis because there is a desperate attempt of the body to produce them. So it can be equal or it can be slightly increased. You find that there can be a defect in the leukopoiesis as well as the megakaryopoiesis. Lymphocytes and plasma cells are unremarkable, and mitosis can be reduced. Sometimes you will be finding abnormal mitosis, particularly when the patient is given a treatment. There will be a lot of mitotic figures because it is responding to treatment. Please have this in mind. We should definitely go back to the text. As I had always been mentioning, lab diagnosis means you should mention the other things. In this case, there is a Schilling's test used for diagnosing B12 deficiency. So the patient is having a deficiency of B12 and he is given a radio labeled B12 orally. Also, you find that a large bolus of B12 is given parenterally. If the patient is going to have a normal amount of B12 in the blood, you find that this will get flushed out in the stools. On the contrary, if there is going to be a deficiency in the body stores, all the radio labeled B12 also will be absorbed and these will be excreted by the kidney. So this is the basic principle that you people should be observed, and you will have to write it in your examination. The counterpart is the folic acid, and the test is Fig-Glue excretion test, form-aminoglutamic acid. Histidine is converted to glutamic acid and it is normally excreted. But what will happen is folic acid is essential for the conversion of histidine to glutamic acid. But when there is a deficiency, there will not be the production of the tetrahydrofolic acid and there will be a reduction in the glutamic acid. So the intermediary product of Fig-Glue will be excreted in the urine, that is diagnosed. Have these two things in mind. So we have finished the blood picture, the bone marrow picture, the other findings in the blood, and now we shall see whether we have left out anything. Look at this particular tabular column. It is a fantastic tabular column, though I have given similar ones in my text of 1 page also. So you find that these are all the investigations and these are all the parameters required for the folic acid deficiency and the B12 deficiency. For example, gastric analysis is normal in folic acid, whereas there can be aclohydria in pernicious anemia. Stool analysis for parasites is negative. There can be the presence of diphyllobothrium later in megaloblastic anemia due to B12. Serum B12, it is decreased, whereas normal over here. Serum folate is decreased. It will be normal in B12 deficiency. So it is essential that you people write everything for the examination, leave alone treating the patient. So this particular tabular column we shall be covered. Now what about the absorption? In fact, this should have been covered earlier, but since I am sticking on to my protocol of the blood picture and bone marrow picture, and so there is a B12 that is taken in the diet, and you find it is bound to a protein, and there is an R binder that is produced by the saliva. This R binder gets bound to it and it goes inside. So R binder is over there. It forms a complex along with this B12 protein complex. And after some time, you find that it is released and the B12 forms a complex with the R binder and it is taken low down into the jejunum. In this case, you find and the ileum. So you find in the ileum, there will be a receptor for it. So this is the ileal mucosa. There is a receptor. And what happens is this intrinsic factor will be there. It is produced by the stomach. It gets bound to it and there is an absorption of the B12 that happens. the R binder is released and the intrinsic factor takes its place. So this is called the B12 intrinsic factor complex, which is taken to the ileum, absorption is complete. So this is very important. Now, how does an anemia develop? An anemia can develop whenever the patient is going to have a decreased amount of intake, an increased demand. But this particular picture tells us something about pernicious anemia. The word pernicious means fatal. It is a separate question itself. It is an autoimmune disorder wherein the patient will be having lots of antibodies. He can be having antibodies against the intrinsic factor. It can be against the various other substances. There is an impaired amount of DNA synthesis also that can happen. So what are the other antibodies? You find that, as I told you, here it is getting bound. So it prevents the binding. There can be a binding antibody. Or there can be a blocking antibody which prevents the further absorption. Intrinsic factor on the B12, and you find this binding, it gets blocked. It is a blocking antibody, and it does not get attached to the receptor. So there is a binding antibody. So these things you people will have to mention. There is a binding antibody, blocking antibody, anti-intrinsic factor antibody, which can be present. Some books also say patients can be having antibodies to the intrinsic factor. So there are 4 antibodies which you people must mention. Anti-parietal cell antibody, anti-intrinsic factor antibody, blocking antibody, binding antibody. These 4 you people should mention. So this will be of paramount importance. And what do the folic acid and B12 basically do? Look at this word over here, DNA. Ultimately, they are associated with DNA synthesis. So methionine to homocysteine, it's over here, and you find that transcobalamin is essential. So there will be a B12 that promotes this particular thing. Cobalamin, methylcobalamin is over here, and when this activity goes on, you find that methyl tetrahydrofolic acid is converted to tetrahydrofolic acid and then methylene folate. This helps in the conversion of deoxyuridylate, deoxythymidylate to finally DNA. So ultimately, the DNA synthesis depends on the folic acid. The folic acid metabolism also depends on the B12 synthesis. So whenever there is a defect in it, there can be a folate trap and it is not utilized for further synthesis of the DNA. These things you people should remember. I would like you people to kindly go to my book, R.A.T.S, where megaloblastic anemia has been explained very well in 2 chapters and 1-page book. There again, it has been described in detail, naming the Addisonian pernicious anemia, what is the blood picture, what is the bone marrow picture, what is the differential diagnosis of macrocytes. So in this condition, we are finding macrovolocytes, whereas you find that macrocytes can be found in other disorders such as aplastic anemia, liver disorders, thyroid dysfunction, etc. Hemolytic anemia. So this again is a wonderful flow diagram from LabPDF, thanks to them. So it is useful for us. So impaired DNA synthesis and ultimately defect in nuclear maturation leading to megaloblastic anemia, and it results as a macrocytic anemia over here. And the picture of it we like to see. He has shown a large metamyelocyte also, giant metamyelocyte. Homocysteine to methionine is one function, and thymidine to DNA. This is another function. This is also a beautiful flow diagram. I would like you people to kindly make use of the entire illustrative diagrams that I had shown for you people. I hope that you people will do it. So here again, there is a summary of, so there is a blood picture, a normal picture, and then a peripheral blood picture, in which apart from the macrovolocytes, I'll be finding the giant or the hypersegmented neutrophils. Inclusions such as Howell-Jolly bodies and Cabot rings can be seen. This will be the bone marrow picture showing the megaloblast. And what are the other lab diagnoses? One is a Schilling test, other is a Figloop test. And what are all the other parameters involved in the folate deficiency and B12 deficiency is given in this chart. The mechanism of pernicious anemia is given over here, and you'll have to mention all the antibodies that are involved. And ultimately, what is the function of the B12 and the folic acid in the synthesis of the DNA? It is also associated with atrophic gastritis, which is an incidental finding, it is said. So kindly go to it, go to the text. I would like you people to read it vividly because it has been asked as a university essay question any number of times. I would like you people to kindly answer the question. Leave alone the chart or the slide that you people get. Thank you.